Care. We are so grateful that you have joined us. Again, questions, we'll take them. Put them in the Q&A and we'll get to them either throughout the presentation or definitely we'll try to get as many as we can at the end. I'm talking quickly because I've seen this presentation and there is a lot of ground to cover. So I'd love to go through some of the housekeeping items on the screen. We've got a disclaimer about the fact that this is for general informational purposes today and that it's providing general guidance, and during these unprecedented changing times, we're providing the best information that we can at the time. Dr. James McGuire is our guest today, and many of you have signed up simply on the name alone. You know, he's a renowned expert when it comes to wound care, the director of the Leonard Abrams Center for Advanced Wound Healing, and he's also the professional clinical scholar of the Temple University School of Podiatric Medicine in Philadelphia, Pennsylvania, representing Philadelphia today. When it comes to wound care and edema management, he is a respected authority and at the forefront also of treating diabetic wounds, saving limbs, reducing amputations. This is his life story, and he's known globally for wound healing. Our agenda for today is, here's 3 major bullet points. And Dr. McGuire, feel free to bring your presentation up so that we can hit the ground running.
I can do that.
We're going to be talking about how to treat wounds during a pandemic, why edema management is so important, and also the use of intermittent pneumatic compression during COVID-19. We'll also get into some technology that you can use to stay connected with your patients at this important time in history. Eric Ansart, who is the president of Lymphopress USA, will be speaking to us about that. We love your questions. We're so glad that you're here. We hope that life is returning to a little bit of normal, somewhat normal. Thank you for your hard work on the front lines, taking care of patients at this time. And even beyond COVID-19, we are all about educating and being connected with our referral sources. So here we go. Dr. McGuire, it is all yours. We're so honored to have you with us today.
Thank you, Brenda. Let's see how far we've gotten with, oh, wait a minute. Here we go. I'm going to have to do this.
I sort of ran through the housekeeping while we were getting set up here, so.
I want to find out why I'm not, my slide, there we go.
Here we go.
Slides were not advancing right away. So you went through the disclaimer, you went through me, you went through that.
There's the agenda.
And more. This is the agenda. We're going to be talking a little bit about how COVID-19 has impacted our particular clinic in inner city Philadelphia, which has some real particulars that maybe a lot of you are experiencing also in your communities as well. Kudos out to those people that are working diligently to take care of patients in this time period, and particularly take care of patients that have been kind of disenfranchised by being moved out into the community where they have no access to the expertise of medical professionals other than by telehealth and home care. And I'll give, my wife's in home care, so I'll give a big shout out to those people that are providing home care for all the wound care patients and doing physical and occupational therapy with patients that are at home at this point. They're doing a terrific job, monumental job, and working extremely hard under very difficult conditions. It's tough to be in protective gear in a geriatric household that's being maintained at 90 degrees, which I've heard from a number of our friends in the field. So kudos to you guys. You're doing a great job, and we'll be out of this pretty soon, and it's not going to be very long. So this was interesting. This was the Alliance of Wound Care Stakeholders, Lee Rogers and other people, and they were talking about some of the things that are happening in the kind of the shift in healthcare. And what we don't know is what's going to happen in the next couple of years. Like after we've gone through this and kind of seen what it's like to do lots of telehealth and lots of healthcare over the phone and treating patients in numerous different ways, what's it going to be like in the future? And that the shift we have an underline there means managing wounds to prevent wound infections, to avoid ER visits and hospitalizations is what's paramount. During this COVID-19 crisis that we've been in, we've been working really hard at keeping people out of our clinic and out of the hospital emergency room. Those have been quite crowded places. Most of my patients are a little frightened to go into places where it's particularly crowded, particularly hospital situations. And we've been trying initially, everybody kind of freaked out initially and kind of kept everybody away from our clinics. And I think that was to the detriment of many of the wound care patients that we took care of. Two leading causes for outpatient wound care visits. I have this up because we usually think of, DFUs, VLUs, and pressure ulcers, pressure injuries, as your three major wound care types. But I really liked an article that came out by Carolyn Fife recently where she talked about the real wounds that we take care of, which are wounds with no name. And by that, she meant that these wounds are attached to patients that have numerous comorbidities. This is analysis of Medicare data set, and that the major wounds are not DFUs, VLUs, or pressure ulcers or pressure injuries. There are surgical wounds that dehisce, traumatic wounds that never heal, chronic ulcers with no name. What they meant was these are ulcers attached to patients with several of these comorbids down here: chronic kidney disease, stroke, COPD, chronic heart failure, atrial fib, and depression. And any three of these diagnoses produce what they call the Medicare trifecta and give you a seven-fold increase in spending over the average of the treatment of that Medicare beneficiary. And I would say a seven-fold increase in difficulty in managing these patients and coordinating care. It's not just what you do in your clinic, but it's also what everybody else is doing and whether you're in communication with each other. Venous leg ulcers are open skin lesions on the leg or foot, usually on the leg, lower ankle, that's in the area affected by venous hypertension or reflux. They are affiliated with a significant lymphedematous component in this. And chronic venous insufficiency, where you're suffering from fluid overload in the limb for a very long period of time. And many of us believe that the edema that we're always fighting is a lymphedema. The old idea that it's venous edema, it's really a venous condition that leads to a lymphatic overload. The lymphatic system just can't handle the volume of fluid that's being produced by the venous insufficiency, and you begin to get a buildup of, transitate initially and then exudate later, that water edema, that pitting, doughy edema initially, that gives way to brawny edema with numerous skin changes. Most of these, about 80% of all venous disease qualifies as chronic venous insufficiency under the definitions of numerous organizations that we see. Venous disease is very prevalent in the community. The prevalence of varicose veins is greater than 20%, affecting 11 million men, 22 million women, and these can all go on to create significant problems as we age. 8% of Americans have advanced cardiovascular disease with skin changes and ulceration. Not ulceration per se, but definitely skin changes. They're on that SEEP continuum. That's the SEEP classification, which is the classification for the development of venous disease over time, and then culminating in a SEEP 6, which is an open ulcer on the leg. 21,000 patients have a diagnosis of venous ulceration every year. So we always want to talk about the whole circulatory system, as I mentioned before. We like to think of it as arteries down, veins out, fluid in, fluid out, and we often neglect the fact that there's another circulatory system. We have this nice closed loop system, and there's another circulatory system, which is the lymphatic system, which is an open-ended, nodal-centric immunovascular system. And I like the term. It has open collectors up underneath the skin, which are picking up fluid and bringing them back out of the subcutaneous spaces where they have transidated out or into the subcutaneous space from the overloaded venous system because of venous hypertension, high blood pressure, kidney disease, cardiovascular disease, congestive heart failure, whatever produces that excessive fluid overload in the system, driving it into the subcutaneous space. And the lymphatics are this open-ended system that collects it all and brings it back in. It filters out bacteria, viruses, and other things that are in the system through nodes that alerts the immunological system in the body to the fact that there's an infection risk, and then they trigger an immune response. Without that system, we would just kind of blow up into a blueberry, like in what was that? I can't remember the movie, but I remember the little kid that just ate the candy and blew up into a great big ball. So here's your collector system, lymph capillary. What?
That's a Willy Wonka.
Willy Wonka. That's right, Willy Wonka. I had thought of it, and I said, no, I'll come back to it. One of my favorite movies of all time, because I'm a big Gene Wilder fan. And Gene Wilder's house was just up on the market, so if you might want to buy Gene's house and live in the home of dreams. Okay, so the lymphatic capillaries, they have this beautiful lymph network, and if you notice, it's right under the skin. And that's why when you see somebody doing a lymphatic massage on somebody, they're not beating down on the system and like trying to get the muscles and push that fluid up out of the limb. They're very slowly, gently manipulating fluid into the lymphatic collectors and back up through whatever part of the lymphatic system which is still functional, trying to develop new channels, new ways for fluid to move in and out of that limb, often aided by lymphoscintigraphy and other assessment tools that we have today that can show you where to move that fluid so that the massage is actually more effective. This is the process of Phlebolymphedema, and patients move from a condition of chronic venous insufficiency into a situation where, usually because of problems with it's not so much the deep system or the superficial system, but it's the veins that connect between the superficial and deep system. Those valves tend to go first. The fluid builds up in the leg. You have this high filtration pressure. The system has high pressures. It's losing fluid to the outside world, transitate, and you get a massive overload, and this lymphatic transport capacity is greatly exceeded. That's when you see pitting edema. When this happens over a period of time, you begin to see skin changes, like in that lower right photograph, where it starts to become discolored. They may have episodes of vasculitis. They may have some thickening of the skin, scaling that starts to show up, hemosiderosis from RBCs or red blood cells getting kind of popped out into the subcutaneous space and then removed by the polys and then digested and leaving that hemosiderin behind, which goes from a low protein edema to a high protein edema when the inflammatory process is triggered by the proteins that escape from the system. You start to develop a fibrous response to the inflammation, leading to fibrosclerosis, the inevitable lymphatic damage, which you begin to see in the lower left-hand picture. And then finally, you'll get a situation where oxygen tension is low, patient is very susceptible to minor injury, a scratch, a bug bite, a bump, or just a spontaneous eruption from dermal disruption ulceration may result in the development of an ulcer on the limb. And this process goes on. Once you have a venous leg ulcer, you have about an 80%, 70 to 80% chance that you'll have another one in a couple of years. And as this process goes on year after year, the limb becomes very, very stiff. Brawny edema sets in, and you begin to get more of a chronic Phlebolymphedema, like a phlebitic generated lymphedema in the leg. And the problem with lower extremity circulatory disorders is it just, in general, patients get shuffled around, the recurrence is common, and people are often ignored until they get to the point where they have a CEIP-6 classification, which is they have an ulcer. It's very common for physicians to sit and look at varicose veins for years, to look at skin changes. And when they don't present with itching and scaling and ulceration, there's no great pressure to move forward, and they will often not write for stockings, not refer patients for ablation procedures and other things that may help them early in the running. And then by the time things get to the point where they're beginning to get ulcerations, they've already gone through that whole Phlebolymphedema process, and they're in tough shape at that point. Referral for lymphedema early in the running is very difficult to often get physicians to do. So during the COVID-19 crisis, we basically used, this is Rogers and Lavery and Joseph and Armstrong got together, and they kind of put together a kind of a tiering of patients. I think was very helpful initially. We sort of used this in our clinic. We had stable patients that we tried to keep out of the clinic and maintain at home. Initially it was, we were just waiting for phone calls, and then we were starting to let the patients know that we were available for phone calls, and then that we were available for video telemedicine calls for patients that had significant problems they wanted to discuss. We were initially closed for a couple of weeks, several weeks, and then we started to open 1 day a week. Then we tried 2 days a week, and we ended up going back to 1 day a week. Most of the clinicians were out. We would only have 2 or 3 clinicians in at any one time. And we were trying to treat only patients that were either serious or presented with something that was critical after a phone evaluation determined that the patient needed to come in. That unfortunately, that plus a fear of coming to the clinic and all the information that people were hearing on the outside kept patients from coming in. The other problem that we had is that being in Center City, Philadelphia, and having a lot of patients who are on Medicaid and Medicare and various levels of assistance, we didn't have the capacity to telehealth. I mean, patients had cell phones, but they had very poor cameras, or they were in their 70s, 80s, and were not particularly adept at adapting to some of the technology we were trying to use. We were trying to use programs that was, quote, easy. All you had to do is click the link. And I remember the first time I did that, the patient said, "What's a link?" And I said, "It's the blue writing." And they laughed. And we eventually were able to establish a connection. Sometimes they have younger family members that are helping. But lots of patients we don't have the capacity to connect with, at least not at the level that we want. And then we were starting to Zoom with patients, but the quality of the Zoom video is so bad that understanding dermatological changes, understanding subtle wound-based changes, getting the lighting right, getting the angle right, plantar wounds, trying to get a person to hold a camera and pick up a plantar wound was almost impossible. So I initially made a lot of requests to let's just open up. We needed to be open for wound care patients. I've continually throughout this made the case that wound care patients are essential patients. Wound care centers are essential centers to keep open during a healthcare crisis. It is essential for us to be there for patients. I had a patient just today that came in who was trying to stay out, didn't want to come in, was afraid to come in, was getting home care for a little bit. But what she basically came in with was a 20 cc bulla that extended from the plantar surface to the dorsal surface that she had developed from an ulceration that was kind of developing under a thick plantar callus that hadn't been debrided in 2 months. And she ended up coming in with just shy of having it explode on her at home and develop an infection at the site. So she was lucky we got her in. We've also had patients with severe lymphedema, like multiple wounds on their legs. And the difficulty that we're seeing is that we have this infrequent visit or patients aren't coming in. We have home care people that are doing their darndest, and they have actually been kind of cross-trained into taking care of wound care lots of times. People were running around in home care. We took a lot of our patients initially, and our original approach to this was when we found out we would be out, we saw as many people as we could and then got them scheduled for 2 months away that were routine foot care. People that were wound patients, we immediately ordered 2 months of home dressings for them, so they would have dressings, made sure they knew how to put them on, Those that were difficult, we set up with home care right away so that they could receive, weekly or biweekly home care during however long it was going to last, not knowing it would be 3 months or 4 months or longer. But that happened all over the city, and a lot of the home care people were overloaded with work. We also had home care people that would see patients that were not, we're not used to dealing with lymphedema or large venous leg ulcers, or managing these type of patients outside of the clinic, or not being the ones that are like normally seeing that level of wound care. And I had various degrees of specialization seeing my patients, everything from people with very little or no wound experience to people that were very experienced in wound management. And we would do our best to talk people through. It was great when there was a nurse in. My ideal telehealth visit is when there's a home care a nurse in with the patient. They're helping with the camera management. They're relaying information to me, and I'm getting what I would normally get from one of my assistants being in the clinic, or because we work with students, one of my students working with me all the time. So we talked about limited telehealth equipment, denials at the door. We had patients that were coming in here to be seen, and they would have a fever, and before we could actually talk to the screener to let them know that maybe they had a fever because they have an infection today and we'd like to see them, they were turned away. We had to kind of make that communication initially, make sure that people that were coming in with maybe a fever secondary to a developing foot infection or leg cellulitis were not being rejected at the front door of the clinic because they needed to come in. They didn't actually have COVID-19, they had an infection. Logistical problems with transportation. Many of our patients come here by public transportation, which was one, limited, and two, scary. So they didn't want to do that. They had trouble getting being moved around by limited drivers for the normal transportation systems that we have in the city. So everything went haywire. So we had numerous undiagnosed infections. People didn't want to go to the ER. I always felt guilty sending anybody to the ER because they were overloaded with other things. And we had problems with people running out of supplies, miscommunication between home care nurses and us, whether they were like being seen by home care or whether they were just receiving dressings from us. Because of the rules and regulations regarding dressings, the number of dressings that patients would get, people that were draining severely were getting limited numbers of foams and all the things that we have as qualifications on home care dressings. And we had patients that were in pain. The thing that happened to me is in Pennsylvania where I am, I have a little key that I have to put into the computer when I'm doing any kind of narcotic pain reliever. And a lot of patients, I left here without it that day, so I did not have the ability to do narcotic scripts at home. And then when I finally got into the clinic, got it, and brought it back home, I found out I couldn't use it on my home computer. I had to be in the office on the original computer it was set up on. That changed eventually, which was very helpful. But a lot of patients went with inadequate pain medicine for very long periods of time. Even the non-narcotic pain medicines, the non-opioids, were still not getting to patients regularly because they had phone call problems or other reasons for not being able to get in touch with us. So you have difficulty of consistent patient care during this time, and wound care centers were essential care for patients, but they were closed or significantly restricted. Patients were afraid. Hospital visits were not desirable for them at the time because they had a lot of admissions. Philly wasn't as bad as New York, but for a while there, we had quite a few COVID admissions. And we had patients getting cellulitis, wound infections, which we talked about. And then, how do we compensate for all this reduced activity on patients? Patients are less active. They need to use this muscle pump. They need to walk. But most people that are sitting home are watching TV, sitting in chairs, sitting with their knees bent a lot. They're not doing the kind of exercise that they needed. Eventually, we got to where we could order some tele-PT for patients, and we could get them OT and PT into the home to help them out. And my wife, who does home care, was actually with a number of patients doing Tai Chi exercises with them by video, like Facebook or FaceTime Facebook. That's like my desk has a little sign out that my students lovingly gave me that says "Okay, Boomer," and I demonstrate a lack of computer efficiency on a regular basis and use of proper terminology. So she was doing FaceTime to do Tai Chi exercises with patients to keep them mobile, keep them moving. So without that muscle pump, without that walking and exercise that they might get in a normal situation, they were beginning to develop more edema. So there was a significant activity shortage for these patients. And without activity, we need additional compression options for patients. Static compression options are out there. There's, wraps and all the many things that we do. Single, multi-layer, short and long stretch dressings, when appropriately applied, work very well. But lots of times they were in situations where they were trying to put on dressings, family was trying to put on dressings that maybe they had relied on us to do for a long time. And the home care nurses are putting on dressings, many of which had not put on multi-layer compression dressings on a regular basis before. So we have all these options, the short stretch bandages, long stretch, multi-layers. We use both a combination of short stretch and multi-layers, not too much. I don't particularly like elastic wraps or long stretch dressings unless patients are very good at applying them and re-wrap several times a day. Self-applied Velcro, and stockings and elastics things. But then finally we get down to the segmental compression devices. And I can tell you that was actually a godsend for a lot of our patients. A lot of them got to the point where they weren't coming in. They had been in their compression wraps for 2 weeks, and I just insisted that they just had to take them off and to kind of either try to bathe or clean their legs. And then the only thing they had were the dressings they had on hand, which I tried to call in for them quickly, and the ones that had the compressive devices at home, such as Lymphopress, who's sponsoring this, and I'm very happy that they're doing that. Patients that had that had something they could use 2, even 3 times a day to work to keep the edema down in the leg. Compression garments are helpful, but many of you know that even though patients have these wonderful things, they can't get them on. I mean, to put on that one garment that you see there, it takes 2 people and a crane to really get all this stuff on. And a lot of patients don't have the hand strength. A lot of my patients can't see their feet. They're too obese, and they really need tremendous help donning and doffing and getting these devices on. So when they have something else that they can use that's an adjunct to this, and we're not saying that the segmental compression pumps are the only way to treat these things. They aren't, but they are very, very active adjuncts. And in this particular situation, were very helpful for patients. When we were able to get them at home, they could get decongested, they could get a compression 2 or 3 times a day. Those patients had lower incidences of cellulitis. Hopefully their wounds improved, and it's been shown that using compression devices, segmental compression devices, and compression adequately results in quicker wound healing. They're actually fairly easy for people. Even patients that can't get stockings on can usually get the garments on and turn the machine on. So patients, when they know it's helping them, they usually are very compliant with using the devices. And it's able to reduce healthcare costs in the sense that you don't need as much of the other care sometimes as you do as those patients that are using the compression devices. It reduces cellulitis in people. This is severe lymphedema with cellulitis. And patients with lymphedema are 71 times more likely to develop a cellulitis. And a lot of it's vasculitis. I realize vasculitis is misdiagnosed as cellulitis frequently, and vice versa. People that have a cellulitic component or an open wound infection component are often misdiagnosed as vasculitis too. But pneumatic compression actually helps decrease the incidence of cellulitis in patients that are receiving it on a regular basis. The Lymphopress device, which I've used for many years, I found it was Medical Solutions and now Patriot Medical, and this particular device was a device that they have used all along. is an extremely helpful, like a segmental compression device. One that is has all the components that you need to do it right, have the right number of segmental like segments in the garments, has the right pressure and the ability to alter those pressures based on pain. It's extremely important that if you have an ulcer like that one that you see in the picture, and it happens to be incredibly painful, that you can still get compression and bypass the heavy compression on that one segment and allow the patient to get care in the rest of the limb, which will decongest the limb and make everything better. Lymphopress and segmental compression pumps in general, they're comfortable. This one particularly has a short cycle time, and they pause between the pressure cycles, which helps a little bit with tolerance. They have a full deflation, which facilitates a lymphatic uptake, gives it time. They have overlapping chambers, so you're like it's like doing a hand massage where you put one hand behind the other and you're moving along gently. Prevents reflux, dermal backflow, and pressure gaps, so you don't have like a just doesn't shut off and turn on and shut off and turn on. It slowly moves the pressure through. Very easy to use and clean, and inflates to fit, so you don't have to worry too much about making it exact. And a wide range of pressures. We talked about the importance of having the ability to select pressures for different areas of the leg. Education for patients. Brenda might want to talk about this a little bit, but they have a great app that they use with the Lymphopress, which actually helps with risk reduction in lymphedema, risk reduction and identification of things like cellulitis because of the video component, and the emphasis on skin care and manual lymph drainage and monitoring is part of this particular app.
Yeah, in fact, first of all, thank you, Dr. McGuire.
Oh, you're welcome.
We hear so many testimonies from thousands of patients every year who've experienced what intermittent pneumatic compression through Lymphopress can do for them. To have someone of your stature speak to its efficacy is so valuable and so important. And at this time when we are really trying to stay connected in a very disconnected world, LymphoTrack can make such a difference. In fact, Eric, I would love to throw to you to talk to it and show us some photos about how this unique app has brought technology into the picture to really connect the patient and the therapist.
Absolutely. And Dr. McGuire, thank you very much.
And I will tell you, Eric, right from the get-go, that when I went on LymphoTrack, being the okay boomer that I am, I found it extremely easy to use. So,
well, that's good. And I know there is,
you know,
our patient demographic certainly sometimes can have some challenges with that. We definitely have recognized that there is a big push just in medical products in general to be able to provide the power and the freedom really to the patient to be able to do some self-monitoring. A lot of our devices, we've always had that understanding, which is why we allow the flexibility for a patient to change pressure, cycles, you know, a lot of different functions within the device. And that's just been kind of a mindset of Lymphopress. Mm-hmm. And this is really that next step of progression where LymphoTrack, it gives the patient the ability to be able to monitor some of those most measured, you know, statistics, leg circumference. If we go to the next slide, I think some of them are listed there. But we can use that smart app, and it's available either through Android or the iPhone. So wherever it is free to patients. So if you're curious about that or curious about using it, you don't have to be a Lymphopress patient to use it. One of the questions we get frequently is, what about the data? The data is not shared with any third-party organization. We don't see that data. It's solely stored on the patient's phone. But what it does allow the patient to do is to take some personal measurements of watching edema reduction or wound reduction and share that information with their clinician. And kind of the vision of this was once a patient is discharged from a wound care center or from a physical therapist, sometimes that patient will see a regression, and we want the clinician to be able to call that patient back if they're monitoring this with them. So if the patient is taking regular measurements, it can send those measurements along to the therapist or to the doctor. The doctor might be able to look at that and say, hey, I'm seeing a regression of your edema. It seems like it's coming back, or it's moving into a different area, or maybe the wound is changed or is reoccurring. let's bring you back in for a reevaluation and just make sure everything is okay. And it was really that connection point of putting the power and the freedom in the hand of the patient, and then connecting the patient and the clinician even after discharge, so that we're all working together as one team to make sure that we're moving the patient forward. If you can move to that, yeah. So these are some of the items that we're able to monitor. You can do circumference, skin color, pain levels. All of those things can be tracked within the app. Wound size. And this is just a quick picture. Actually, if you could go to that next slide, Dr. McGuire. So this is a really quick picture of what the data looks like. Again, this is a free app for any patient to use, and it's solely stored on their phone. But they can take this information and they can simply click a button. You see it there in the bottom right corner of the picture of the app. There's that little three-pronged or two-pronged app or picture there. They click that, and that allows them to email or text message a chart directly to their clinician. So the therapist may pick that up and they'll be able to see a monitoring chart that shows activity level. Maybe it's gone from 3 activity sessions a day to 2, back to 3, as you're seeing there in that. But it really allows the patient to stay in touch with the therapist, and for the therapist and the doctor continue to monitor the patient even after discharge, so that we can make sure that continuum of care is as strong as possible. So we're excited about it, and hopefully, Dr. McGuire, you mentioned that you've looked at this app. Hopefully, you'll be able to find a spot for this with some of the patients that you're treating.
Yep. No, I definitely will. It's I want to show it to them, and I want to give them the opportunity to have it to use it at home, because I think it's great feedback. One of the things you mentioned was when a patient actually sees progress, and sometimes it's hard to see progress. I mean, a lot of my students, they're here for a month, and they see a patient over the course of 4 weeks. Then they'll leave, and they'll often come back, a couple months later. And some of the patients, the venous leg ulcer patients, often take 12 weeks or so. And they're amazed at the amount of progress that they see when they're not actually watching the patients. And it's hard when you're doing something on an everyday basis to see improvement. But when you can see on a graph that you're slowly getting better all the time, that you're reducing limb size, the wound is getting smaller, that your symptoms are decreasing, that you're very encouraged, and you're encouraged to actually continue with the care that you're being asked to do.
Wow.
And it's important that people realize what this can do to you in the course of your lifetime, and how important it is to intervene with patients early and do early management strategies. Not that I want to put the pump out of business, but you may never need one if you're properly managed up front with diet, reducing weight, exercise, wearing compression hose. That's what we should be doing all the time. And then when patients get really bad, doing the things that we need to do to heal them and then prevent it from coming back, which is using these segmental compression pumps, which are very helpful.
Do you think that there are any initiatives that have begun during this COVID-19 pandemic that will last and will effectively change practices moving forward?
Oh, I think telemanagement is going to be very interesting. Once patients realize if they continue to reimburse for telehealth the way they have been, they loosened a bunch of regulations to get telehealth things available so that you could actually be reimbursed for the time and expertise of delivering phone generated or video generated care. If that's maintained, many patients can be taken care of with less frequent visits, but more frequent telemonitoring. And the use of adjuncts in the community, like we may not have to have a great big clinic. What we may have to have is regular communication with the patient, and home care coordinated by telehealth, and an occasional clinic visit for things like debridement and specialty dressings and application of grafts and other products that we can do in a clinical situation, and then manage the patient with telehealth and home care. I think that's, I'm telling my students all the time, I said, plan to be outside the clinic a lot. You don't plan on having an office where everybody comes to you all the time. You may need to be going to them in many ways, electronically and physically, to provide the care they need.
This is your forum. Is there anything that you would like to say to our referral sources out there, people that are walking the walk, working in the front lines? What would you say to them at this unprecedented time in history?
Oh, just that they're angels. They are blessed emissaries when they choose to go out and put themselves at risk and care for other people. And I made that argument at our place too. I'm not frightened to do what I was trained to do to help people. And these people they're not scared to go into a home with somebody with COVID and put on protective gear and care for them. And they should be, it's not just hospital people, and they're wonderful. I mean, what the people in the hospital have done, guys and gals in the hospital have done is amazing. But these people that are home care people that are delivering the level of care, and they're not shy about seeing patients. They're brave individuals that are out there doing what they're supposed to do. And hats off to everybody that's out there caring for these patients. And we are there for you. Like, the healthcare system is here for you. We don't take a day off unless we have to, unless it's mandated. And when they lift some of these restrictions on clinic, we need to be back in there right away.
Dr. McGuire, you mentioned, I guess we're getting to the close of our time, and I know there's probably hundreds, if not thousands, of your students around the country that look to you for different input.
Those that came today. Thank you all if you showed up just to say hi. God bless you all. Like, I can't go anywhere without bumping into a student that I trained at some point. I am extremely proud of the people that I had the ability to contribute to their education. I mean, when I see what people are doing and the level of care that they're rendering, I'm always proud when I see my students out there doing what they do in history. Absolutely. To get experience.
Absolutely.
I know a lot of people were taking notes, and we want to encourage everybody that if you were on the webinar today, you will get a link with the actual recording, and so you can refer back to it. There's a lot of wisdom here. Just like you said, there's nothing like talking to the expert right there. And also, we want to remind you that we have some upcoming webinars in June. June is Lymphedema Awareness Month. On June 3rd, we're doing a really interesting webinar with Catherine Seal and Leslyn Keith about the ketogenic diet and also some of the psychosocial impacts of lymphedema. So even though this COVID-19 space is hopefully shifting and people are resuming work as normally as possible, we still want to continue with education. It's critically important. I know that you've provided an amazing forum for people today. Any last words, Dr. McGuire?
From your lips to God's ears on that opening.
Yes.
It really is time. It's time to get out there and get going and see people again in the open air and be able to see somebody's face and a smile. And
without a screen separating us.
not thinking you may be robbed. No, I appreciate the opportunity. I love having the opportunity to do these things, and hopefully that people got some information out of this that's helpful to them. And if not, at least we had a good time together and enjoyed a good conversation about a difficult problem that something like LymphoPress can really help manage. So thank you.
Thank you, Dr. McGuire.
Thank you so much. And thanks everybody for joining us today. We really appreciate it. We're here at LymphoPress to help you make life better for your patients. And again, thanks for all you are doing in the midst of all this craziness right now to continue taking care of people. Have a wonderful day, everyone. We'll see you at the next webinar. Bye-bye now.